Patients with ear disorders. The external ear is the aurica, the pinna, and the extraoral auditory canal, which is the protection of the ear. The middle ear has 3 tiny bones, the malleus, the incus, and stapes, and they receive vibration sound from the tympanic membrane. The inner ear contains internal structures, nerve impulses sent to the brain, like sound, responsible for equilibrium and balance of the body. Ear and hearing changes associated with aging. It's drier impacted cerumen, loss of tympanic membrane elasticity, decreased bony ossicle movement, degenerative changes of cochlea, disturbed vestibular function, diminished hearing acuity, decreased ability to hear high-frequency sounds. Subjective data is difficulty in hearing. We have dizziness, vertigo, pain, blurred vision, headache, itching, pressure, or full feeling, ringing, popping, buzzing. These are some of the things that your patient will tell you during their assessment. Objective assessment, drainage, hearing loss, tenderness to palpation, dried secretions, the cerumen, and deformities of the ear. There are 3 common tympanic perforations. The first one, A, is a small central perforation. Hearing is usually good. For B is a large central perforation around the handle of the malleus, and the hearing is usually poor. And then we look at C. This is marginal perforation of the Schrappnell's membrane, and hearing is usually good. Otoscopic exam is a visual exam of the ear canal and tympanic membrane. Audiometer presents sounds used for diagnosing sensory and conductive hearing loss. Otoscopic exam for adults. The pinna is pulled up and back to straight out the ear canal to visualize the tympanic membrane. The audiometry tests the ability to discriminate between sounds, voices, and degrees of pitch and loudness, and results are plotted on a graph. Interventions for patients with ear and hearing problems. External otitis, diagnosed through otoscopic exam, not necessary to pull the pinna because it presents with red, inflamed, tender ear and ear canal with or without drainage. If drainage is present, obtain a culture and sensitivity. Treatment is Tylenol and codeine for pain, a cotton wick for antibiotic ear drops, use of new gauzes as a wick. Be sure that ear drops are at room temperature. Place the patient on the side for at least 2 minutes and remove the wick and place the cotton ball. Be careful not to contaminate the dropper. May require systemic antibiotics if entire canal is red. Warm, moist compresses apply gently over the ear. The swelling of the ear may block hearing and may cause dizziness. Drainage may be serosanguinous or purulent, and treatment is pain meds, antibiotics, and warmth. Cerumen wax is the most common cause of an impacted canal. Other blockages include vegetables, beads, pencil erasers, insects. Irrigate canal with a mixture of water and hydrogen peroxide at body temperature for impacted cerumen. Cerumex softens wax. Carefully remove the foreign object. Assessment. Here we're looking for a history of ear infections, recent upper respiratory infections, allergies, check vital signs, inspection of the outer ear, inner ear for drainage. Pathophysiology. Inflammatory disease of the middle ear caused by bacteria invasion usually begins in childhood. Signs and symptoms caused by pressure of fluid may permanently damage middle ear. Subjective. Hearing loss, feeling of fullness with the ear, pain, headache, malaise. Objective, foul drainage, fever, bulging and or perforation of the eardrum, conductive hearing loss. Interventions to obtain culture of drainage, systemic and topical antibiotic therapy, decongestants and antihistamines, cold and heat applications. Teach patient how to administer eardrops, monitor vital signs, control noise level, and minimize distractions. So what's the difference between acute and chronic otitis media? Chronic is almost always some type of drainage. Chronic otitis media is usually painless. Surgical therapy may be indicated with chronic otitis media. The tympanic membrane is damaged, perforated is the only way to fix is with surgery. Now in this picture, a normal left eardrum and an ear with acute otitis media is on the right. Note the thin, clear tympanic membrane eardrum on the left. The ear with acute otitis media has a bulging tympanic membrane due to pus in the middle ear and increased redness over portions of the drum. A myringotomy is a surgical opening of the pars tensa of the eardrum. Operative procedure includes grommet, a polyethylene tube, placed through the tympanic membrane. Postoperative care, keep ear canal and canal free of other substances while the incision is healing and keep head dry for several days. Acute or chronic disease of the mastoid process generally occurs secondary to otitis media. Subjective, tenderness over the mastoid bone, headache and ear pain, anorexia, vertigo, observations for facial paralysis, and report immediately as this may indicate damage to facial nerve. Report headache or stiff neck and immediately report this as it may indicate meningitis. Objective, draining from the ear if perforated, increased temperature, swelling over mastoid process, reddened thick tympanic membrane with possible perforation. Interventions, antibiotics, eardrops and/or systemic. Cleansing of the ear, surgical intervention, mastoidectomy, radical or modified tympanoplasty. Trauma or damage to the eardrum and ossicles may occur by infection, by direct damage, or through rapid changes in the middle ear cavity pressure. Eardrum perforations usually heal within 24 hours. Use preventive measures to protect the ear from trauma. Tumors are removed by surgery, which often destroys hearing in affected ear. Benign lesions are removed because with continued growth of the neoplasm, other structures can be affected, damaging the facial or trigeminal nerve. When possible, reconstruction of the middle ear structures is performed. Continuous ringing or noise perception is one of the most common problems with ear or hearing disorders. Tinnitus cannot be observed or confirmed with diagnostic tests. When no cause is found, therapy focuses on masking the tinnitus with background sound, noisemakers, and music during sleeping hours. Vertigo is linked to ear issues. Dizziness can result from other issues, including dehydration, low blood pressure, etc. Advise patient to restrict head motions and move more slowly, maintain adequate hydration, take anti-vertiginous drugs, prevent loss of balance accidents. Labyrinthitis. Infection of the labyrinth. Meningitis is a common complication of labyrinthitis. Treatment with systemic antibiotics, bed rest in darkened room, antiemetic, anti-vertiginous medications, and psychosocial support. Acoustic neuroma, benign tumor of 8th cranial nerve, surgical removal via craniotomy, extreme care taken to preserve the function of the facial nerve. Meniere's disease, chronic disease of the inner ear causing vertigo, cause is unknown, but follows infections of the middle ear or trauma. Subjective, vertigo, nausea, headache, sensitivity to loud noises, sensory hearing loss, usually on one side, and tinnitus. Assessment questions. Can you describe your symptoms? What makes it worse or better? Do you have a history of allergies or infections? What do you do to feel better? Retching or vomiting? Diaphoresis, nystagmus during attacks. Audiometry test to document unilateral hearing loss. Nystagmus, abnormal rhythmic, jerking movement of the eyes continually move horizontally. Treatments, diuretics, antihistamines, anticholinergics, vasodilators, neuroleptics, vitamins or Valium, low salt diet, restriction of caffeine, nicotine, and alcohol. Prevent onset of symptoms, allow patient to move at their own speed, slowly. Prevent injury and promote safety. Lie down if symptoms occur. Teaching patient about what types of food to avoid and identify support systems. Hearing loss is one of the most common physical handicaps in North America. Conductive hearing loss is a problem occurs by conditions interfering with air conduction, occurs in the outer, external, and middle ear and impairs the sound being conducted from the outer to the inner ear. Most common cause of conductive hearing loss is otitis media with effusion. Treat underlying cause. Diagnosis with otoscopic examination, audiogram, treatment, usually hearing aid. Sensorineural hearing loss is due to impairment of function of the inner ear or its inner structures. Common causes of sensorineural hearing loss: loud noise, drugs, presbycusis, atherosclerosis, hypertension, prolonged fever, Meniere's disease, diabetes mellitus, and ear surgery. Sensorineural hearing loss primarily affecting the cochlea and 8th cranial nerve, acoustic factors that affect the nerve pathways that lead to the brainstem. Treatment of hearing loss. Assisted devices like hearing aids, cochlear implants, tympanoplasty. With the tympanoplasty, postoperative care includes antiseptic soap gauze packed in the ear canal, clean dressing, patient to lie flat with head turned to one side, and the operative ear facing up for at least 12 hours after surgery. prescribed antibiotics, and activity restrictions. Hearing aids, clean for cerumen, check batteries, difficult for elderly to change them, keep them in a safe place, case or labeled denture cup, speak clearly and in regular tones, do not yell, hearing aid amplifies. Lip reading, speak clearly, don't chew gum, and have good lighting. Sign language, use of interpreters. Just like any culture, a language barrier can be a problem. Hand motions, pointing to the bathroom or hand a urinal to the patient, using boards with sentences or pictures on them to point at. Write it. Remember that some may not be able to write.